Welcome to prIME Oncology's Year in Review on Molecular Testing. My name is Dr. Jeff Oxnard. I'm here with Dr. David Blanchard.
Hello, Geoffrey. It's a pleasure for me to be here.
So we have so many new targeted therapies for our patients. We have so many treatment options, and the question here is, how do we connect our patients with the best options? What's your standard approach when a patient presents with metastatic lung cancer?
So I think there is two things to do. Firstly, it's an histological type, because probably we might determine the treatment according to the histological type, adenocarcinoma, squamous,
Right.
and so on. So this is the first thing. And the second thing is try to identify molecular alteration. I think this is a priority. This is what we try to look systematically, because this is probably the best option. And notably, we are looking for the EGFR, we are looking for the HALK, ROS1, and the BRAF, because I think this is foremost important molecular alteration for which we can probably start a treatment with targeted therapy.
Definitely. In the United States, those are the targets where we have a first-line FDA-approved regimen, though we have these other rarer genotypes which are popping up: MET splice mutations, RET rearrangements, HER2 mutations, increasingly targetable, new data with a RET inhibitor. So it seems like 4 becomes 5, 6, 7, 8. There are all these targets to find for our patients. How do we do that efficiently?
I'm agree. So I think there is two ways to things. You can do one by one.
Yeah.
So you can say, okay, we are doing the EGFR. If it's negative, I'm running for the HALK. If it's negative, I'm running for the BRAF, and so on. I don't think this is the best way to perform for our patient, particularly because we are in first line. We can't wait too much time, and probably it's most costly vision. So what I think we are doing, it's a multiplex testing. And so more and more we are performing all this type of molecular alteration on the same way, on the same platform, and at the same moment after the diagnostic. So I would say there is two things. You can look to the mutation. The gene fusion, probably it's much more complex. It might be different, and you might, and this is what we are doing, for example, for the HALK, for the ROS1, we are started by immunohistochemistry.
We have the same. We have very reliable IHC. We run an IHC. When we do the initial histology typing, get the IHC for ALK, the IHC for ROS, the IHC for PD-L1, and cue the next-gen sequencing then for the other variants.
Right. So that means you're doing 2 times. You start by the NGS.
We start with the IHC during the diagnostic workup. We're reflexing ALK-ROS and PD-L1 IHC, and then we have a hybrid capper next-gen panel that gets our EGFR, KRAS, BRAF, MET, HER2, maybe get some rearrangements that we miss sometimes, but it's the IHC that's most reliable to find those rearrangements. For you?
Same thing. Same thing, particularly, we have firstly the result by immunohistochemistry. It's quite speed by our pathologist to look at the PD-L1, to look at the ROS1, and to look at the HALK. We at the same time as we have the diagnostic, and after we are running by NGS all the panels. So we have a panel of 74 different genes trying to identify molecular alteration for our patient.
A lot of centers are still using FISH. FISH is the established assay. I think if you have reliable IHC, a lot of us have moved to IHC because it's quicker, maybe uses less tissue. But I don't trust FISH quite as much as IHC in the hands of my pathologists. But I know that a lot of centers still use FISH.
I'm quite confident by immunohistochemistry, particularly for the HALK. I would say for the ROS1, I would be probably more prudent, and we try to confirm generally the ROS1 alteration by FISH. And so this is something we try to perform. But that does not mean we are waiting the result of FISH to start the treatment. So that means particularly if you have the adenocarcinoma, never smoker, seems to be ROS1 positive by immunohistochemistry, I think we have enough proof to start the targeted treatment like crizotinib.
Yeah, I think the timing is important. Docs are really confused about that. When do you wait for the NGS versus when do you just start? And whereas I think we all would prefer to get the results, to get to the targeted therapy, sometimes you need to pull the trigger and just move on what you have and use the genomics as a backup.
And particularly, I would say it's quite important because notably if you have the PD-L1 status before the NGS result. So you might be confused. So I don't know how you do this. So you might deal with a patient highly positive PD-L1. You still do not have all the panel gene testing.
And what you're describing is you don't trust that PD-L1 for a patient with a genotype. And I think that's really important, right? PD-L1 can be very fast, but a PD-L1 positive EGFR mutant is not going to respond. ALK mutant, ROS, MET, we know that if you have that genotype, that's a marker of genomic simplicity. And those patients with simple genomics, even if they're PD-L1 positive, are not going to have a response. And so you have to consider both of these things, right? It's the genomic complexity that allows PD-L1 to be effective. And that's this tumor mutational burden, right? I kind of think of it as the complex smokers' cancers. Those are more likely to have the immune therapy response. The simple non-smokers' lung cancers, which have a genotype, are less likely. It's not that clean. Like a non-smoker can still get a smoker's lung cancer, and a smoker can still get a non-smoker's lung cancer. But that's that tension between the genotype and the PD-L1. We prefer to have them all together, but you can't always have that.
So it's important to have all the results before to decide any treatment, finally. And particularly if we focus on the BRAF population, on the MET population, for which you have a smoker. So that means if you are just waiting and, okay, the patient is a smoker, PD-L1 positive, I will start with the immune treatment in adenocarcinoma, but finally is BRAF or MET mutated, probably this is a wrong decision. So
what do you do when the patient doesn't have tissue, right? What about that patient who presents and you have a little bit of tissue, you can get PD-L1, they're a non-smoker, do you go back for more tissue? Do you use a liquid biopsy as an alternative?
I would say there is to my point of view, we are discussing if it's easy to perform a new tumor tissue biopsy by core CT scan biopsy, and we can get it in the week. So probably we will discuss to have a new tumor tissue biopsy, but systematically in parallel, we will look to the circulating tumor DNA on the plasma.
Yeah, I agree.
Tumor
is the truth, right? Tumor is the most reliable way to get that genotype. But I see plasma as that shortcut, that for some patients, quickly gets you to the EGFR result and can efficiently create targeted therapy options instead of waiting for tumor genomics.
But that depends on the circulating tumor DNA, what you are able to look for, which mutation. So that means I don't know, are you looking just for the EGFR by digital PCR, beaming PCR? Do you have NGS testing, a plasma panel testing on the plasma?
Yeah, our internal validated assay is just a ddPCR for EGFR, so that's our quickest result. We can get it in a few days. But you're right, for some patients, you need more complex analysis. I have a patient with an aggressive cancer I saw recently where I needed to start them on chemotherapy. I couldn't get that biopsy, so I sent plasma NGS. And that gives me, not perfect coverage, but a pretty good coverage of a range of genomic alterations. She has aggressive disease, so I feel like she has shed of DNA. And chemo wasn't working 3 weeks later, but we found a MET mutation and could start her on MET inhibitor therapy. So I actually go back and forth. I use a plasma NGS in certain circumstances. If I'm proceeding for a biopsy, I use a quick ddPCR as a shortcut to try to circumvent that biopsy. I kind of pick different assays for different situations. Yourself?
We are doing the same things. We have a panel of gene on the circulating tumor DNA, and so we try to identify the mutation, if it's positive, clearly. And generally, we might be able to have the result in 1 or 2 weeks. So after, there is a limit. So that means you are in first line of treatment. So if you are waiting, the tumor tissue biopsy is negative, you are going to circulating tumor DNA, it's generally, we have the limit to 2 to 3 weeks. So for EGFR, you may have the result in 1 or 2 days. But if you need extra day, generally, I start the chemotherapy and waiting the profile. And probably I will adapt the treatment in second line of treatment.
Now, what variants do you trust that your plasma assay can find versus can't find? Right? Where do you think plasma is not established? Because for me, the thing I'm most concerned about is amplifications, right? Like MET amplification, a cool biomarker, you really can't reliably find it in plasma. Fusions, it's hard enough in tumor. I don't think you can reliably find it in plasma versus EGFR and KRAS, where I think plasma is at least better, though not perfect.
So that's why I think when you screen the patient, it's still important to go to the tissue biopsy, particularly to look for the amplification, to look for the translocation. I think this is currently the limit of the plasma. I think this is not the same discussion where you're looking for mutation of resistance because you know what you are looking at. But when you don't know what you are looking at, I think the tissue is still the standard, particularly for the first line to try. So I think we need to push further for the tissue. We can add this circulating tumor DNA, but I think this is extra analysis. This is what
and you can't get PD-L1 in tissue, right? PD-L1 is a meaningful biomarker for the genome-negative patients. You can't get it in blood. You really need a good tissue specimen. Sometimes we have the tissue in front of us, right? You have the brain resection, the pleural effusion, always better to go for easy tissue than to use blood as a shortcut. So you mentioned resistance. How does that calculus change at resistance?
The resistance, I think, you know what you're looking at. So that means if you know the patient is EGFR mutated, if the patient is HALK translocated, ROS1 or BRAF, so after you will focus on specific mutation of resistance. So I think it's much more easier to go on the plasma, and so systematically I go for the plasma testing for the resistance, notably for the EGFR, for the HALK, for the ROS1 and for the BRAF. And I'm quite convinced by the result. Sensitivity, I think it's quite good and quite better nowadays, around 70%, depending on the techniques. But that means in most of the resistance, most of tumor progression, we're able to capture some specific mutation, and particularly for the EGFR, for the T790M mutation, first, second generation, when the patient progresses, it's systematically circulating tumor DNA.
Right.
And we capture only, and we go further to the tissue biopsy, only if the patient is T790M negative on circulating tumor DNA.
I think doctors are still struggling with that, right? Patients, they don't want those biopsies, and so they want to find a way to get therapies with no biopsies. And it's really important that you offer that shortcut to patients. Let's check your blood. But if it's negative, you still need to go to tissue as the alternative, right? And I've had patients who say, "Oh, doc, can we wait?" Sometimes it's true. It's negative. We give it a couple months. We check it again. But for a patient with EGFR resistance, getting that genotyping creates options. Not only T790M, MET amplification creates targeted therapy options. The TATAN trial, we're rolling to small cell transformation, other rare genotypes. So I don't let the patient push back too much, right? The standard of care is the resistance biopsy. The quick plasma testing is a shortcut. Again, we use a ddPCR, very fast, takes about a day. But I know others are using NGS. What's your T790M assay in blood?
For the blood, generally, firstly, if it's EGFR, we're looking by digital PCR. And that means after, if we need further molecular alteration screening, in this case, we're looking by NGS. But digital PCR, particularly when we know what to look for the BRAF, and this is what we try to do for the ROS and also for the EGFR.
And what's good about ddPCR, it's really well validated. It's a very clean assay. I think that benchmark is increasingly being used to validate NGS assays, and they're really getting there. But I still think some to be learned about which of these assays from the NGS standpoint is better. You've said a couple other mutations beyond EGFR. So tell me, how do you think about resistance past EGFR, and how are you using this in your practice?
I would say it's particularly much more touchy for the HALK mutation, for example, for the ROS1 mutation. So because we know there is probably more than 5 different mutations for the ROS1 that have been reported, more than 15 mutations for the HALK. So in this case, this is where we are looking by NGS. And also we look for other type of mutation. As you told, you might have some mutation on the MET, you might have some mutation on HER2, and also some PI3 kinase mutation. So in this case, we need to have something more large that only to focus, just for example, for the EGFR on the T790M. So I don't know what is your practice. If you follow also and try to identify all the mutation of resistance, systematically in the patient, notably for the HALK, for the ROS1?
Yeah, from a research standpoint, we're very interested in biopsies and NGS, right? From a patient care standpoint, where have I seen a resistance mutation impact treatment beyond EGFR? Certainly with ALK now, we have a number of interesting, we have all these ALK inhibitors, right? So we're trying to figure out how to sequence them for patients. Some of the interesting data we saw at World Lung, I thought with the lorlatinib data, was that the response rate to lorlatinib in these previously treated patients was higher in patients with ALK resistance mutations, which is if you have on-target resistance, get a more potent ALK inhibitor. But if you don't have an ALK resistance mutation, reaching for another ALK inhibitor might not work as well. You might have an off-target resistance mechanism. So I don't think about that as much as after crizotinib. Crizotinib is not a great ALK inhibitor, but after lectinib or ceritinib, that's where we're increasingly looking for ALK resistance mutations to think about if we can sequence another ALK inhibitor. The other space, actually, we've had some experiences with MET. So we had a patient who developed acquired resistance to savolitinib with osimertinib in a new MET mutation, and we then switched from savolitinib, one class of MET inhibitor, to cabozantinib with erlotinib, a different type, and have had actually an amazing 1 or 2 year response now. And so it is interesting. Beyond EGFR and ALK, there's a number of places where we're connecting biology and resistance mutations with an ability to sequence targeted therapies, right? And that's what patients want. They love targeted therapies, and they don't want to fall back
Completely
to
agree.
chemo.
And I think for the ROS1, this is the same deal. We have some patients, same thing with a huge response with crizotinib. new tumor tissue biopsy, identify new mutation of resistance, establish some cell lines model with the mutation, with highly sensitive to lorlatinib, and the patient more than 3 years still with lorlatinib. So this is a way probably to try to go further and to try to identify new things. If you don't look, we will never discover new mutation of resistance. And particularly, this is an issue because currently you can use whatever the HALK inhibitor, whatever the type of mutation of resistance. But I think we can probably increase the benefit for each patient just trying to adapt the treatment with this type of mutation of resistance. And it's quite so easy nowadays, particularly again with the circulating tumor DNA. So we need to emphasize these things prospectively in all the patients.
I mean, I think we all have those amazing outlier cases, right? I have the patient who developed acquired resistance to EGFR, a MET amplification, I added a MET inhibitor, then developed T7am, I switched the EGFR to osimertinib, and you stretch along year to year, connecting different targeted therapies together for these patients. Yes, they're outliers, but they make you amazed at how precision therapy for resistance creates options. And it just relies on the need to keep going to biopsies and keep sort of pushing to the next step. In the resistance setting, how do you mix immune therapy in PD-L1, right? Does that ever become one of your tools for resistance?
Honestly, until now, I tried to push in further line, really in late line, the immune treatment. All the experiences was quite disappointing with the immune treatment. Whatever the PD-L1 status in this population with a specific molecular alteration, generally the benefit is really low for the immune treatment. So I still believe that the chemotherapy have a right place in this population. For the immune treatment, honestly, I'm quite disappointing.
Yeah, I agree with you. And I'm not convinced that as they become more complex and resistant, they ever really acquire a mutational burden that makes them interesting, right? They still are fundamentally a genomically simple cancer. And so I agree with you. Immune therapy is pushed back to really a very late line because it's very uncommon to see responses.
And you look for the tumor mutation burden in this population?
No, I
when
mean
they progress?
conceptually, right? Okay. I think to myself, if you keep treating them, eventually they become high mutational burden. No, they never become a smoker's cancer. They always remain fundamentally a genomically simple cancer where you can't really trust that immune therapy is going to be an effective salvage.
Because what about the patient with histological transformation, for example, a EGFR mutated that become small cell transformation? You think there is a room to look at the TMB and perhaps this population to have a higher benefit of immune treatment?
Right. What you're describing is that eventually these patients, after you hit the target very hard, the cancer gets very dysplastic. It gets crazy, right? And so we're seeing small cell transformation actually more and more in our practice now after osimertinib, right? So they're T7am positive. We showed some data today that you suppress the T7am, small cell transformation emerges. And I feel like it's emerging more as we inhibit EGFR better. It's an interesting question. Those small cell transformed cancers, are they mutationally complex enough that immune therapy becomes relevant? I'm not convinced. But I do think that just as resistance to initial EGFR inhibitors is interesting, resistance to osimertinib remains interesting as well. And other weird, I'm seeing acquired KRAS mutations. Right? I would never have believed it, right? But now, EGFR acquiring KRAS, two genotypes that shouldn't coexist, but we're seeing them now. So I think there's a lot to learn as these newer drugs emerge about how resistance is emerging and how we figure out targeted therapies for these patients.
Another question that I have in mind, do you follow patients by circulating tumor DNA? So that means, do we need to wait radiological progression, clinical progression to perform molecular analysis, or you think there is a rationale to capture an early molecular alteration, an early mutation of resistance just by circulating tumor DNA and to have an early intervention to start earlier? I don't know, for example, if you see the emergency of the T790M, if the patient receive erlotinib to start earlier, the osimertinib,
It's a great question. I think it's so easy to send the blood test that doctors want to send it, right? And so the question is, when is the right moment? I am not convinced. I have patients even where the CAT scan shows a little growth, and they're like, I feel great, doc. I don't want to change course. So I'm not looking for early excuses to give up on a drug that's working, right? I send a liquid biopsy when they have clinical resistance, right? That's the moment when a liquid biopsy could find something. If they're feeling okay and there's subtle things going on in the scans, I don't reach for the blood test yet. I think the idea of using repeat testing to find response and resistance, very cool. I'm not sure we're there quite yet.
I agree. So that means the standard is still to look at the patient, clinical progression, radiological progression. But Completely agree. More and more oncologists, they're looking for the evolution of circulating tumor DNA and probably change too early the treatment.
And giving up on a targeted therapy that's working.
Yes. So this is an important point. But we need to learn. And there is some trial, for example, like the Apple trial, which will try to answer to this type of question for which you have two different arms, changing the treatment at radiological progression or biological progression. So that probably will bring us some interesting data. But until now, I agree, we should keep this molecular testing, resistant molecular testing, when there is radiological progression or clinical progression for which, and I think for the immune treatment, this is also the same thing. But this is another question. For the immune treatment, do you think there is a rationale to look at specific mutation, PD-L1 patient positive?
Acquired resistance
yes.
to immune therapy, still a research question, I think, not clinically practical.
No, yes.
Any final points as we wrap up?
I think it's quite amazing to have this type of adaptation and to see how we might lead to a benefit in our population, in the patient, and particularly all the recent data we have seen, either for EGFR, either for the ROS1 with quite huge median overall survival. Amazing. Just when we see the result with profile 10,014 for the patient HALK rearranged, receiving first-line crizotinib, and nowadays it's median overall survival more than 15 months. So that means we are not surprised to have this patient alive 4 or 5 years after started the treatment as a metastatic disease. So I think it's amazing, and this biomarker analysis is something quite amazing, and particularly on the blood. So I'm really convinced probably in the near future it will be all done by blood circulating plasma testing.
A lot of optimism for our patients.
Yes, yes, and we have the treatment beyond, so that means this is a case for osimertinib, and probably moving the second or the third generation up front, we will learn a lot and probably see how to adapt the treatment and what will be the mechanism of resistance. So we need to learn a lot. That's fantastic.
Well, that's a great discussion. I think that there's a lot for doctors to keep up with in the molecular space, but it's complicated, but it's worth it for the patients, right?
Yes, I completely agree, Geoffrey.
Great discussion.
Thanks so much again. Thank you.